Hello, everyone, and welcome. I am Kim Welter, and I am the facilitator for the Ohio Health Modernization Movement, which we shorten to OHMM. So if you hear us say OHMM, that's what we're referring to. And we are recording today, so I just want you all to know that. In a moment, well, not in a moment, but later today or tomorrow, you will be able to find this webinar on our website. I've just posted the link to that. So that if you needed to go back and check something that was said, you could easily access it. It may take until tomorrow before we get it up. There's some editing that gets done. Anyway, just very briefly, because I know we have some folks on this particular webinar who are from other states and a little new to who Ohio Health Modernization Movement is. We are the coalition in Ohio that's dedicated to modernizing the criminal code in Ohio around sharing your HIV status with an intimate partner. And we are a combination of folks from AIDS service organizations and grassroots folks. And I'm the facilitator. This webinar is offering CEUs. They are being offered through Caracol, who's one of our coalition partners. It will take 2 to 3 weeks, just FYI, so don't worry about it. Your CEUs will come. We will wait till Friday to allow people to finish taking the quiz and filling out the evaluation that are a must in order to get those CEUs. I will post that link at the end of the webinar. So yeah, you do have to stay to the end to get that link in order to be able to fill all of that out. You can find past webinars of Ohio Health Modernization Movement at that same link that I've posted there, the one that ends in webinar. And future webinars can be found in the events tab of that web page, although the next one, which will be August 11th, isn't up there yet, but it will be soon. I believe that is all I have, other than if you have questions as we're moving through, you can post them in the chat and I will share them with the presenters when we get to the Q&A section, or when we actually stop to do Q&A, you can unmute yourself and ask the question that way as well. Those are all options. If you have questions for me logistically during the webinar, put them in the chat and I will be monitoring it. I'm going to allow our presenters to introduce themselves. So right now, I'm going to turn it over to Amir.
Thank you, Kim. Hello, everybody. My name is Amir Sadeghi. I'm the National Policy and Partner Strategist with the Center for HIV Law and Policy, and I'm one of the folks who will be talking about HIV molecular surveillance with you today. And Bob?
Sure. Hi, everybody. My name is Bob Bucklew, and I'm the Outreach Coordinator for the Case Western Reserve University Hospital's AIDS Clinical Trials Unit here in Cleveland. And I am going to be following Amir's presentation and doing a little bit of applicability to Ohio and where we stand in Ohio with the concepts that Amir is going to be raising.
Great, and Kim, would you like me to just go ahead and jump in? Okay, great. So let me go ahead and share my screen. Let's see. Okay, can folks see this presentation? Okay, great. And everyone can hear me all right? All right, so I'm going to be talking with you a little bit today about the molecular surveillance of HIV, what the policy implications of this kind of surveillance technology are, and speaking a little bit about community concerns around the molecular surveillance of HIV, the implementation and rollout of this program. Here's just some contact information. If you'd like to be in touch, if you'd like some of these slides, I can make them available to you. And I'd also like to just flag that we have a resource, a fact sheet, which I think can be thought of as a companion to this discussion. If you would like to consult it maybe after the webinar, it can be found on our website at hivlawandpolicy.org. So after today, I hope that you'll have a better understanding of what the molecular surveillance of HIV is, how it works, what kind of data is reported and how and to whom it's reported, what kind of inferences public health officials make by analyzing that kind of data. And I hope that you learn a little bit about why people are concerned about the rollout of this surveillance technology, and from there identify some advocacy next steps and opportunities that we can take, and there will also be an opportunity to ask questions at the end. And just briefly, just in case there are any folks listening in who aren't familiar, the Center for HIV Law and Policy is a national policy and legal resource for people living with HIV and their advocates. We host the Positive Justice Project, which is the first national collaboration between people living with HIV, people living with viral hepatitis, and other stakeholders working to end the criminalization of all stigmatized diseases and identities. And to that end, we do legal and policy analysis on issues like HIV criminal laws, but also like molecular surveillance. And we've worked with defense attorneys representing people living with HIV in numerous cases, including Michael Johnson's, and we continue to collaborate with prosecutors as well. So public health surveillance isn't anything new. I think many folks know that. And, you know, I think public health surveillance with respect to HIV and people living with HIV goes back all the way to the beginning of the epidemic. But, you know, there have been initiatives that require doctors to report information to state health departments. You know, with respect to HIV and other communicable diseases and STIs. But what is new, the issue here is that the data is obtained from an individual treatment interaction. And there are also some issues with how that data is reported and analyzed too. But basically, the molecular surveillance of HIV is a public health use of individual treatment resistance information that doctors report to health departments. So it's data that's taken from a drug resistance test to analyze an individual's viral strain, to identify certain quirks that someone's viral strain may have, in order to prescribe the most effective and responsive regimen of drugs to treat that individual. But that data is then used, marshaled outside of that scope to guide public health action. So how does that work? This graph, this diagram is created by the CDC, and it's a little bit messy, so I want to walk through it and explain as best as I can that when an individual is diagnosed with HIV, a doctor will order drug resistance testing to analyze those particular strains that an individual living with HIV, that their virus may have, in order to prescribe the most effective drugs to treat that person. And you know, this happens because because HIV is such a rapidly evolving virus that as it copies itself from cell to cell, it will make mistakes, and it will, you know, that's why no two individual strains of HIV are exactly identical at the molecular level. So what's new is that the information, because of developments in research and medical technology, enables public health officials to analyze that information and use it to make inferences about how HIV is transmitted in a community, and what populations are affected by it. And from there, a provider will report that, that data and information to a state health department all the way up to the CDC. And one of the locations actually that molecular surveillance information is stored is at the Los Alamos National Laboratory, pictured here. So I touched on this a little bit, and that HIV rapidly evolves and mutates as it replicates itself. And because of that, no two people will have an exactly identical viral strain at the molecular level. And from there, public health officials can analyze and make determinations about how closely related viral strains are and how closely related people are in a transmission network. And for these purposes, public health officials can make that inference if two individuals are within 0.5% of if their HIV strains are 99.5% or more similar. So if they're within 0.5% similar with each other. And there's a couple different public health techniques to monitor and analyze how HIV is spread and transmitted through a community. There's the lower tech time-space cluster, which basically is a way to monitor patterns of HIV prevalence within a geographic area. Then there's the higher tech. There's the molecular cluster, which is a term that the CDC uses to describe people who can be linked at the molecular level, whose viral strains are within 0.5% of each other, and they're individuals within a transmission network. And this kind of information is supposed to then be used to guide and inform a public health response and direct public health action on a cluster of individuals with whom HIV is rapidly spreading. So what can public health officials do with that information? It's an evolving question as we're all learning, and the target's moving. As of right now, they cannot identify directionality. Public health officials cannot prove that an individual definitively acquired HIV from another individual, because they cannot rule out that there's an intermediary in that cluster of related HIV viral strains. But I think, you know, it's only a matter of time, and it's all but an inevitability that with rapidly advancing medical research technology and surveillance technology, that may be a matter of time, but as of right now, they cannot prove transmission between two people. And here's a CDC guideline to help illustrate that, because person A and person B may have, you know, nearly identical viral strains within 0.5%, but that doesn't necessarily rule out that there's a third person, a third intermediary in that transmission network. Oh, sorry. So the CDC wanted to make, and is clearly making it, that HIV molecular surveillance is a priority for the Ending the HIV Epidemic Initiative. And in 2017, in an effort to expand the use of this technology, they announced a 5-year funding program called PS 18-1802. And it was a mandate for states receiving public health surveillance funding from the CDC, funding that states really depend on. So states had no option to say no. If they were receiving public health surveillance funding from the CDC, they had to engage in this molecular surveillance program to create relationships of data sharing between providers and state health departments. And that funding announcement caught many members of the community by surprise, because there was very little and basically no at all, no community buy-in or input in the implementation of this surveillance program. And we've seen a debate, members of the community and public health officials have been ensnared in for the last several years. And perhaps in response to that, the CDC a couple of years ago, in November of 2018, announced some updated guidance relating to the molecular surveillance of HIV, what it calls foundational activities to ensure the ethical implementation of the program. And we've just put some of that announcement in a timeline, because they set some figures with respect to time on achieving certain goals in response to this immense public pushback. So by June 2019, state health departments were to begin with that lower tech time-space cluster detection, identifying geographic areas where HIV prevalence has increased and mapping patterns of HIV prevalence that way. But then there was to be collaboration between state and local health departments to facilitate data sharing, creating those policies and really codifying those relationships of data sharing that make the molecular surveillance of HIV and the kind of analysis of this genotyping data possible. By December 2019, there was supposed to be initial community engagement completed on behalf of state health departments with the community of people living with HIV, people who inject drugs, and the people who are most directly affected and impacted by the criminalization of HIV and other policies that discriminate against people living with HIV. And we can see that all the way through 2020, in which we are in right now, jurisdictions were expected to implement action plans based on all of this gathering of community engagement and identifying those gaps in protections around data security and privacy and so on, that by the end of this year, state health departments were instructed to address those gaps. And I think we'll hear a little bit from Bob later, at least how that response has happened in Ohio. And I think what we're really seeing is that there hasn't been much follow-up, and it's certainly not uniform across all 50 states or across all the states conducting this kind of surveillance, that there has been much of a response to this community pushback. So I just wanted to kind of identify some areas, some of these flashpoint areas of community concern and concerns that we have here at the Center for HIV Law and Policy about the rollout of this kind of surveillance, about how it's mandated for states that they have to do so. And some of these issue areas include criminalization, a topic that many, I think, listening along today might be familiar, data security and privacy, consent, public health, scarce resources, and stigma. So I don't have time to do too deep of a dive on the criminalization of HIV in the United States, but I imagine we may be speaking about it a little bit during the Q&A. But Ohio is one of the states that have criminal penalties for the non-disclosure of an individual's HIV status. And here represented on this map, we can see the states that have HIV-specific criminal laws, states that have sentence enhancements that are that apply to people living with HIV, and states where people living with HIV have been prosecuted through the general criminal code, through general crimes like reckless endangerment, aggravated assault, all the way up to attempted murder, although rare. We have seen those kinds of prosecutions against people living with HIV. And then represented here in some of the balloons, we have states that require sex offender registration in the yellow balloons. And green balloons, we have states that have reformed or repealed their HIV criminal laws. And how does the molecular surveillance of HIV, this data sharing and reporting and analysis between a direct patient and provider exchange to identify and prescribe the most effective and responsive treatment regimen for a person living with HIV, all the way up through reporting to state health departments and the CDC, how does that intersect with the criminalization of HIV? Well, it does, because there are many states that have laws that facilitate the sharing and even cooperation of public health officials and public health information in criminal prosecutions. Ohio is one of those states. In the Ohio Revised Code, there is a statute that protects any information that identifies an individual as living with HIV, data relating to an HIV test. But there are substantial exceptions to those protections, some of which make more sense than others. And one that certainly doesn't make much sense at all is that law enforcement can subpoena HIV-related information. They can obtain a court order and receive that kind of information. So I think what this really points to is a dangerous level of cooperation between public health and law enforcement that can really exacerbate legacies of medical mistrust, especially with communities who are most often targeted, number one, by law enforcement generally, but also folks who inject drugs and undocumented individuals, people who are more subject to the enforcement of criminal law. And here is a particular law in Ohio which facilitates the sharing of information between public health officials and law enforcement. So public health officials have stated that they do not believe that molecular surveillance will create an additional risk of prosecution because current technology can't prove directionality, like I noted earlier. But prosecutors can nonetheless use that data as circumstantial evidence. It's something that we've seen in several cases. And the broader issue is that judges and juries may misunderstand the scope of the science, and that's a huge issue. This really, I think, highlights the necessity for a broad and impermeable barrier between public health and the enforcement of criminal law, so that we don't have this kind of irresponsible and dangerous collaboration between the two. Another issue that, I know I'm moving a little bit quickly, but I don't want to take up too much time, and I want Bob to have a chance to speak fully, but I'd point your attention to a 2018 NASDAQ study that analyzed or looked at 10 states and identified a patchwork of policies within those states with respect to sharing medical data between providers and health departments and law enforcement. And what this study shows is that there is no uniformity in any kind of policy between data sharing between these stakeholders and law enforcement, and that statutes, I just pulled one quote that I think is relevant to this discussion, that the statutes and regulations governing health department data sharing for law enforcement purposes still leave a great deal of discretion when evaluating individual requests. So what that basically means is that there are no firm and kind of impermeable protections for this kind of incredibly personal private medical data and how it can be shared with law enforcement officials. And then also on the concern about data security and privacy about this incredibly personal medical information, we often hear from public health officials that molecular surveillance information has been de-identified. The trouble with that is there was a study here, references down below, and I pulled a quote out that basically by using computerized network databases, it can be incredibly easy to re-identify de-identified medical data. By having access to voter registration records, hospital discharge records, even commercially available databases, it can be incredibly easy to re-identify that information, which again, just points the way to why a barrier between law enforcement and the public health apparatus is so important. Some final issue areas that I'd like to point out before handing it off, and actually before identifying some advocacy items, is issues about consent and medical mistrust and stigma. I guess I'll start with stigma because it, the term cluster is a pretty unfortunate term when what we're really speaking about are people living with HIV, and we're talking about human beings. And I think a lot of the language in public health initiatives and approaches that end up treating people living with communicable diseases and people living with HIV as vectors for a disease, and rather than human beings with dignity and autonomy and basic rights to privacy, that's an issue. And that's something that we've seen from the CDC before. There's also the issue that this data has been, and this is something I mentioned earlier, that this data has been obtained in a direct exchange between a patient and their provider in the interest of being prescribed the most effective drugs to treat their viral strain. And that data is then marshaled for public health purposes, often without the knowledge of the individual who underwent that drug resistance testing and now has their data, deeply personal and identifiable data, reported up through state health departments and to the CDC without their knowledge. So patients really have the right, a fundamental right to decide what medical treatment that they receive and how that information is used. And it's really important that when we have policymakers in the room, we make that incredibly clear. There's also the issue of medical mistrust, especially affecting communities of color, communities that have been surveilled in the past, that have been experimented upon in the past. And there's, I think, a lot of concern that doing this kind of public health surveillance and reporting of this data without these individuals' knowledge is not the best way to call people in, and it's certainly not the best way to repair some of these legacies of medical mistrust that take decades to mend. Here's actually, I think, a really interesting quote from Andrew Gans, who's the New Mexico State AIDS Director, who we actually collaborated with on a webinar last year. And it's that, I think, you know, what he's wondering is how does linking two individuals or more individuals who are already engaged in care, who are already getting drug resistance testing, how does that work to get more people virally suppressed? And Andrew Gans in New Mexico urged that the CDC hasn't really answered that question. The CDC hasn't made it explicitly clear that this kind of public health surveillance has a public health benefit if all that it's doing is linking people who are already engaged in care. What does this do to get more people virally suppressed, expand the scope of data security and privacy protections, and also expand the access, the accessibility of care in the first place? So I think from here, something that we can look to are some advocacy steps for us to undertake. And I think, number one, we can demand a moratorium on the use of this kind of technology until the CDC addresses these concerns, beyond laying out an abstract timeline, but rather using their influence to do more than release that joint statement with the DOJ in 2014. You know, there hasn't been much follow-up with respect to modernizing HIV criminal laws since then, since that joint statement. So I think there are some holes in the system that we can focus on, and it's at the state level, we can demand that states both effectively repeal HIV criminal laws and adopt health data protections to ensure that no personal health data can be shared with law enforcement. And I know that not in every state, you know, it's not that in every state a state health department can change its laws, but what it can do is engage with community members who understand these issues, engage with state coalitions like OHMM, and coordinate with them to successfully implement these kinds of legislative changes. We can demand that the CDC hinge molecular surveillance program funding on states certifying that HIV surveillance data and research can't be shared with law enforcement. They've said before that they can't do this because of this patchwork of policies that facilitate data sharing between providers and law enforcement and providers and state health departments. But if the CDC can mandate that states receiving public health surveillance funding, states that really depend on this funding, they can mandate that they conduct molecular surveillance reporting and analysis. They can also mandate for these kinds of changes as well. And we should be pushing state health departments across the board on this. And we could demand that the CDC revoke its 2008 partner notification guidance. I want to move a little bit quickly because I want to hand it over, but here's a basic advocacy action plan that we ask questions to your public health officials about how this public health surveillance is being rolled out, and how much money is being spent on surveillance technologies. Rather, because I think what we often hear is about the scant public health resources that these stakeholders are dealing with, and we should be questioning whether they should be undertaking this kind of public health surveillance and what kind of public health benefit it really has. And speak up, share your concerns with your state or local HIV/AIDS policy director, push back, demand a pause on molecular surveillance until it's clear that, one, essential privacy and data security measures are in place, and that it's voluntary and cost-effective way of preventing new HIV cases, and finally, that rules are in place that explicitly prohibit sharing of identifiable data between law enforcement and immigration enforcement. So with that mouthful of a conversation, I hand it to Bob. Thank you. Here's just my contact information one more time, but I can share all of this with you again. So I'm going to stop sharing my screen now.
And I will start sharing my screen. Thank you, Amir. Okay.
Can we ask questions?
I'm going to only be probably 5 minutes, and then we will open it up. So unless you had something for Amir, something very specific, I don't.
No, I can wait. I can wait till the.
Okay, yeah, I'm going to be real quick here. So can people see my slides? Okay, cool. So once again, my name is Bob Bucklew, and I am in Cleveland at the Case Western Reserve University Hospital AIDS Clinical Trials Unit. Just sort of as an aside, as the other AIDS clinical trials units around the country, we have also been drafted into fighting COVID-19. So we're in this fight, but obviously where our passion is HIV research. And that is my email address, rob2@case.edu. So please feel free to contact me. I want to talk a little bit about Ohio. So the CDC funds are made available for the health departments, and Amir talked a little bit about this when they adopted molecular surveillance. And in that period of time, and I'm not really sure, I don't think we're really sure where all of this money went, if it all went to molecular surveillance. It seems very expensive. But when the Ohio Department of Health agreed to do this, they received over $7 million, which in public health terms is a sizable chunk of change. So it was very, very explicitly tied to getting money. And as Amir mentioned, that for health departments, that is extremely important. So consequently, what the Ohio Department of Health did was changed its reporting requirements. And in the state of Ohio, that did not require a law change. In fact, it didn't even require a regulation change that would be up for public comment. It really was the Ohio Department of Health's director can change reporting requirements when it comes to HIV, and that's what they did. And so now what happens is when a doctor, let's say I find out I'm HIV positive, I go to the doctor, my first visit, they're going to draw bloods, they're going to send that blood out to a laboratory to be tested to see if I'm resistant to any drugs. That test from the laboratory is now required to be sent to the health department. And it basically gives the DNA structure of my HIV virus at that point in time. And that isn't something important to remember in that point in time. I will then most probably start taking antiviral medicines, anti-HIV medicines, which is actually going to change. That virus is now simply going to start changing. It's going to keep evolving. So the blueprint, what somebody gets is that initial, or what the health departments get is that initial DNA analysis of my HIV. In Ohio, and the Ohio Department of Health, to my knowledge, and we're pretty much tied in, has not conducted stakeholder or community consultations about their program. They might have talked to their statewide planning group or something like that, but I don't think anybody on this call would say that that could constitute any type of real true stakeholder or community consultations. So this just all sort of happened. It happened under the radar. Mir did a real good job of this, talking about public health surveillance, and it's an old concept. It's an extremely old concept, but with HIV, or in the state of Ohio, public health surveillance happens with HIV, tuberculosis. It happens with SARS-CoV-2, if we had funding for that, and syphilis. And so what happens is we get a report of, let's use syphilis. Syphilis, a disease intervention specialist, a human being at the local health department is going to go out and talk to the person that was recently diagnosed, and they're going to try to find out who could possibly have been exposed to syphilis, who this person had been exposed to sexually. And then what will happen is the disease intervention specialist will go about contacting the names of the people who were given to them by that initial person. The theory here, and it does work in specifically in certain cases, like such as syphilis, is, we would offer, the disease intervention specialist would offer them testing, prevention, and treatment. So it's a great concept. Obviously, it can be fraught with problems because it is all of a sudden other people know extremely private personal medical information about individuals, and they're going around sharing that with other people. So this is fraught, and I think people on this can be appreciated. One thing I do also want to say is disease intervention specialists are under pressure or under scrutiny, let's say, scrutiny from the Ohio Department of Health, which funds these, that a certain person, that they need to get names from these people. So this isn't just a service like, oh, I would like to offer you this service. There's actually pressures on these disease intervention specialists to get names from people. And so if people say, I don't want to give you any names, which is a right, that's sort of a ding against that individual disease intervention specialist. So that's important to know when we're talking about training of disease intervention specialists and the priority. What is that person's priority? Is that priority not to get their number of true contacts increased, or is it to protect confidentiality? And so these folks are in somewhat of a difficult position. So it is argued that molecular surveillance, what we're talking about, may be able to fill the gaps that traditional interviewing does not provide. That's questionable. I'm not going to explain how that happens, and I think Amir did raise when the guy from New Mexico, like, how is this actually going to work? How is this actually going to help? It still can be a little confusing. But I do understand from a public health perspective why this type of information may be helpful. Okay. So advocacy points, and Amir went over these, but I wanted to bring a few more up. One is when I go to my doctor for the first time with HIV, generally my doctor is not going to sit down and explain to me, now I'm sending this blood out to you for this purpose, but then there's this whole other purpose that's going to happen. And I don't think, I would be surprised if people are being informed about this reporting requirement from their doctor on their first visit to an HIV clinic, which is traumatic as hell anyway. I just don't think that's happening. And when people find out that, it could be very understandably, a perceived breach of trust between the doctor, their individual doctor, and a patient. And that is a trust that we know a breach in that trust does not do the patient any good. It also undermines individual and community relationships with public health officials. Okay, that whole concept, I really remember somebody who I really like and trust, and I always want to see what they say about issues. And I was talking to him about this, and he said, all I know is when I see somebody knocks on my door and says, I'm from the health department, I turn and go the other way. We need to establish trust relationships, but that's based on activity, and that's needs to be based on real truth. So with this, as with so many other things, that the potential negative consequences will impact disproportionately on African American and Latinx individuals and communities, and particularly sexual and gender minorities within those communities, injection drug users. So people already very legitimately feeling marginalized and over-surveilled are the ones that are going to feel the most negative aspects of this. Ohio's criminal laws are horrible. They're horrible. And they are enforced. And they are enforced rigorously, without mercy, without compassion. It's Ohio, one of our slogans was the heart of it all. Brr, not a good heart here, okay? It does not matter in Ohio whether you transmit HIV to somebody. It is a crime, a felony, to not disclose your HIV status to someone prior to having sex, even if that sex has no chance of transmitting HIV. It's really a very horrible law. People living with HIV also face enhanced criminal penalties for various things. With our laws being so horrible, there is an argument that molecular surveillance doesn't add any more risk because you don't have to transmit the virus. All you have to prove is that I wasn't told that this person's living with HIV. That's a little, I mean, it's an argument that our laws are so horrible, this isn't going to make them any worse. But obviously that is not an argument for molecular surveillance or for this current status. So if we get our laws changed and OHMM is successful, and I believe they will be someday, we've got this lurking back. We do have this thing, and if this isn't addressed, it would be another way for people to be caught up into the legal system. Advocacy points, one, and this is something that we really do need a firewall, or I think Amir called it an impenetrable barrier between the collection of this information and law enforcement. Silence on the subject leaves discretion to judges, and you don't want to leave discretions to judges if in this type of case. Even though technically we don't have to prove transmission of HIV or anything like that, this type of information could very well be misused by prosecutors and misunderstood by judges and juries. And once again, it needs to be said, this will impact disproportionately on African American, Latinx individuals and communities, particularly sexual and gender minorities and injection drug users. This is a place I do believe if we act quickly, we can get our voices heard. The End the HIV Epidemic, it is a national initiative coming through the CDC and the NIH and all the HHS. Its goals are very, I don't know, they're very high goals. You could see them there. There are four different pillars, they're calling them, of this. And the fourth pillar is diagnose, treat, and prevent. Those are, oh, great. Those are all things we want to do. The fourth is respond. And respond in terms of the CDC is molecular surveillance. Okay. So this End the HIV Epidemic targets the 50 counties or 48 counties in the US that has the most HIV. And there will be additional funds coming in them. Each one of these these counties need to have a plan, a community plan going on. There are 3 Ohio counties, Hamilton, Franklin, and Cuyahoga, which have our big cities in them, are part of this initiative. Each of these 3 counties are currently doing a plan on how to implement the End the HIV Epidemic. Everything's being fast-tracked, of course. The plans are being created now and are due to the Ohio Department of Health by September 30th. But I know I'm part of the advisory committee up here in Cuyahoga County, and I saw some folks from Cincinnati and Columbus, and I know this isn't the whole state, but this, I think, it's very, very reasonable for us to include our concerns about molecular surveillance in those plans. And so I think we could work on that. This is my second to the last slide. And this is Amir. Tell everybody about this. Tell everybody about this and contact our city and county health departments. What's going on right now? What's going on right now? Who has these disease intervention specialist workers that are going to look at this? And where are our training and confidentiality protections? How are these folks being protected from being pressured to use this information and any information they collect to not skirt the, but bump up against the law, bump up against the regulations? So I want to thank folks. I am part of a group that has been working on this issue up here in Cuyahoga County. In fact, I didn't plagiarize their slides, but I took a lot of their work and their hard work and investigation in preparing mine. So I do want to thank Lisa, Jean Sylvia, Mariah Dick, Professor Sharona Hoffman at the Case Law School, Dr. Ann Avery, who is everything to us, everybody up here in Cuyahoga County, and Theo Russell. So with that, I will turn it over to Kim, and I think she will be fielding our questions.
Yeah.
Thank you.
Thank you, Bob and Amir. And Nate, I think you get to go first on the questions.
All right, number one, if it's my understanding, you do that genotype unless somebody has a active viral load, correct? Amir?
That's right, yeah.
Okay, so this would impact newer people coming into the fold. Old dogs like myself that's been suppressed for decades, you know, we're less at risk with this. But this is really going to impact more, not that it's not important to me because I'm an advocate, but this is really going to, that first time newly diagnosed person who is going to be, they're going to have the kitchen sink thrown at them as far as testing and genotyping and things like that. Okay, what is the impact on older people like myself? Older in the epidemic?
I could just, Nate, you're perfectly right. For folks that have been around for a long time, that your DNA, your HIV DNA has not been sent anywhere. And so it really is rolling forward. If somebody was, you know, if somebody maybe 6 months ago, and part of that timing piece, so this really is moving forward. So in terms of how this would impact you, I'm not sure how that would, other than it would be impacting the whole epidemic.
But part B of my observation is that people that have been in the pipeline a long time, like myself, are more seasoned advocates. How can we prepare the most uniquely impacted segment to advocate for themselves? I've been around the block a few times. I can advocate and be a part of this. I'm part of Kim's organization. But again, doesn't that really increase our need to train people to advocate, especially the people that are going to be impacted the most? I'm done. Thanks.
Okay.
Well, and you know, Nate, I think it's my understanding that folks, you know, sometimes undergo drug resistance testing if their viral load goes up. If that can change, can it not? And you know, I think age doesn't really have that much to do with this, so far as people of any age can acquire HIV. People people, I think, but I hear your point about long-term, survivors and individuals living with HIV.
We have several questions going on in the chat, so I'm going to move us a little bit along on this. And I do see the one hand that's raised as well. But Lauren, you have a question?
Yes, ma'am. Thank you guys for your presentation. It's been very helpful. I'm actually on this call. I'm a co-chair, and my co-chair, Mukam, is on this call. She discovered you guys. Shout out to her. This is great information. For our Respond pillar for our EHE work group here in Fort Worth, Texas. And Bob, whenever you mentioned that at the end that you guys are looking at that too, I'm wondering if there are other folks on here that are also a part of that. I know that Brandy is here from New Orleans and that she's also working on that. I'm wondering if anybody would be interested in maybe setting a date not too far along in the future, but before our plans are due back to the state, to kind of do a little bit of back and forth and sharing of our identified goals and strategies and the activities that we're going to be doing to work toward our plans to end the epidemic in our areas in regard to molecular surveillance. I know I would love to pick brains and kind of trade ideas and things like that. So if anybody else would be interested, I'm going to share my email address in the chat and feel free to reach out.
And if you miss Lauren's email, I could probably find it in the registration information. So we have a question from Sydney, which is, will this allow them to request lab results from before the law was enacted in criminal cases?
I'm sorry, Kim, could you repeat
Sure.
that? Whether, yeah.
Will this, so molecular surveillance, I presume, allow them to request, so I presume that's prosecutors, to request lab results from before the law was enacted in criminal cases?
I don't believe so, no.
Okay.
No.
I'm not an expert, but I think I understand that people who have been thriving for a long time didn't get this testing done. So if we went back to the 90s, there wouldn't be the test results to request, correct? I see Amir's kind of nodding his head. Hopefully I got that right. All right, a question for Amir from Beth. You mentioned DNA molecular levels that are closely related within 0.5% that are being observed. What does the closely related number mean or prove?
Great, thank you, Beth. I just typed a response, but the closely related means that viral strains are so similar that public health officials who analyze that data, who analyze the genotyping drug resistance data, can infer that 2 or more people are related as partners or as needle sharing partners, sexual partners, and so on. They can make inferences based on how closely related the strains are because HIV so rapidly evolves, it so rapidly changes as it copies itself that that can lead to an inference and analysis that if 2 people's strains are within 0.5%, they're closely related as sexual partners or as needle sharing partners and that kind of thing. It's a public health inference based on the similarity in genotype data.
Okay. There is a thread, by the way, in the chat around, so Dorian, around the question just before this. So I recommend you checking out that chat. Dorian's involved in it, Lisa Jean's commenting on it in things that I didn't understand. And I appreciate their expertise there. Let's see. Yeah, and then Catherine jumped into that. Any other questions for our folks?
You mentioned
oh yeah, Paul,
hand.
I forgot your raised hand. I am so sorry. Go ahead.
Okay, well, let me just say at the outset, I'm a retired public health official from the HIV/AIDS program in Florida. And I appreciate very much, first of all, Amir's presentation, and then I was really glad that Bob raised showed the slide with the 4 pillars of the HIV epidemic. I think that it's so important, the fact that there cannot be directionality established. And I want to ask Amir, you stated that this information has been used as circumstantial evidence in cases. Do you happen to know, I mean, can you cite specific cases where this has happened? Because to me, the lack of connection or the ability to connect is absolute here and should not stand up in court. So that's my first point. Second point is just to mention as an aside that Paul Sachs and others at Harvard University published a paper a couple of years ago, which they said that the resistance threshold for integrase inhibitors is so high that maybe resistance testing needs to be taken out of the treatment guidelines. And that's a blow, actually, if that were to happen, I think, to this idea of 75% reduction in new cases by 2025 and 90% reduction by 2030. I just think in public health that is so important. And being able to identify new people at risk by disease intervention related to these, I'm sorry to use the word clusters that are found out through this process, it's so important to add that to PrEP and treatment as prevention and so on. It can be so valuable. So I'm just looking for specifics on cases where this has been a problem, and also mentioning that we may even lose part of the value of this type of molecular surveillance.
Yeah, and Dr. Ahrens, to answer your first question, if you take a look at our source book on HIV criminal laws across the country, assumed transmission has been used to base convictions widely. I mean, so many cases. Nushawn Williams here in New York, I believe that, so even though that directionality cannot be proven with this kind of data analysis and surveillance, that judges and juries who aren't often adequately educated on the science can make assumptions and misrepresent or misunderstand the scope of what the analysis of that data pertains to. It's just too many to count. So many cases where someone is assumed to be a sexual partner, and this kind of data can lead to those convictions as well, especially when you have widespread policies across states that require the participation and cooperation of public health officials and public health information and data in criminal prosecutions.
Amir, I'm going to just jump in real quickly because it is 12:59. I have put the link to the quiz and the evaluation in the chat box. Please go grab it, especially if you're looking for CEUs for this. I will continue the conversation, however, but for people who need that and need to go because it's 1 o'clock, please do that. But you also have a raised hand from Lisa Jean.
Thank you, Kim. I appreciate it. Hey, Bob. It's so good to see your face. So thanks for representing today. I do have a question. So Amir, as you said, this has really kind of been, the CDC has really not given states a choice, or it's already kind of, the horse has left the barn. And so my question is, since this is already starting to happen, the data is being collected, are there any best practices? And I do appreciate the continued advocacy for putting it on hold and stopping and all of that. However, my question is, are there any best practices as far as how it's being implemented? Are there ways to implement it that would increase benefit and decrease potential negative impacts to communities?
Yeah, I think you know, I'd like to hear Bob's answer on this too, but I think you know, number one, state health departments that are receiving the funding from the PS 18-1802 funding program to do this kind of, to conduct this kind of public health surveillance, state health departments can either directly work to change their laws to reform HIV criminal statutes in their state to modernize them. The CDC can require the creation of privacy protections that can require patients to be notified and opt out, because patients can't opt out as of now of having their drug resistance data and information reported to state health departments and up to the CDC. So I think there are a lot of things that state health departments could be doing, because I would like to briefly touch on some related public health approaches that I think with the molecular surveillance of HIV create a trend. Because in Louisiana, I think it was last year, there were updates and changes to the sanitary code, which required the reporting of identifiable information for patients who both tested positive and negative for several STIs. Even if you tested negative, identifiable information would have to be reported. So that's alarming. And also here in New York, there was an initiative moving through, there was a proposal moving through the state legislature to remove the basic requirement that a provider verbally engage their patient prior to an HIV test, and where that notice can be provided indirectly. Maybe there's a boilerplate sign on the wall, maybe there's a video playing in the waiting room, but there are a lot of patients and a lot of people that kind of notice won't reach. There are people with visual and auditory disabilities. There are people with, there are people who don't read and speak English. There are people who are worried about the collateral legal consequences to an HIV diagnosis. So state health departments and the CDC could be doing a lot more to answer your question, to effectively and ethically implement this kind of surveillance. Because I think the more people we alienate from coming in to connect to care because they're worried about the consequences to an HIV diagnosis, they're worried that they're going to receive treatment that they didn't consent to, they're worried about data and information that can be personally identified to them, is shared, can be accessible through breaches of any kind, can be shared with law enforcement. This connects also, I think, with how contact tracing can be ethically and effectively implemented, because people will only cooperate if they believe that cooperation will not bring themselves to harm, will not bring their communities or family members at risk. So I think, state health departments can work more to push for modernizing criminal statutes that target people living with HIV. And they can also work to create impermeable barriers between law enforcement and public health, which would really, I think, add to the legitimacy of public health surveillance, which, to touch on Dr. Aaron's point, there is public health benefit to public health surveillance. It can be useful, it certainly can be, but it has to be ethically implemented, and it has to be done in a way that respects individuals' privacy, their rights to bodily autonomy, and so on. Bob, did you want to jump in?
I think you did a great job. It really, to me, a lot of it is getting the law enforcement. Sounds like we could be talking about any topic now. Get law enforcement out of it and treat it as it is, public health, and that to me would be the best thing. And also to make sure that the DIS workers, the people that are actually using this information, are trained and are not under weird pressures to use it to push the edges of what is valid in its use. So that would both be my things. So I think you covered it.
Thank you, Amir and Bob. But we have now run 5 minutes over, so I'm going to have to cut us off, although it's clear that this conversation could continue for quite a bit longer. Lisa, I do see your question. Perhaps you could Lisa, Jean, you could reach out to Amir directly to find out that answer. Thank you, everybody. I really appreciate it. If you, again, if you want those CEUs, make sure you click on the link. I will also send it out in a follow-up email to those who were registered tomorrow. And thank you, and join us next month in August when, especially if you're an attorney, when we will be presenting information particularly for Ohio attorneys around HIV criminalization. Thanks, everybody. Bye. Well, I don't, let me turn off the recording.